Hi, my name is Justin Anzalone, and this is my Unit 4 case connections, and I have chosen to utilize cases 1 and 3 for this presentation. So case 1, a newborn girl appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. The question proposed initially is which diagnostic would be the best to distinguish between an urea cycle disorder and a disorder in beta oxidation. We'll first start off with our best diagnostic test, which would be urinary acids. Urinary acid testing would assist in the diagnosis of a urea cycle disorder and a beta oxidation disorder. In urea cycle disorders, urine uric acid levels are of importance, and in beta oxidation disorders, dicarboxylic acids, glutamic acids, ethyl malonic acids, and 2-hydroxyglutarate are all of clinical importance. With that being said, urinary acid testing will be best utilized to distinguish between a urea cycle disorder and a beta oxidation disorder. Moving on to blood glucose, which is option A, blood glucose measurements would assist in the diagnosis of a beta oxidation disorder. Beta oxidation disorders are accompanied by hypoglycemia. Hypoglycemia in beta oxidation disorders is a result of an inability to metabolize fatty acids to produce acetyl-CoA, where acetyl-CoA would activate pyruvate carboxylase, which then activates gluconeogenesis. Moving on to option C, serum fatty acids. This diagnostic test would assist in the diagnosis of a beta oxidation disorder, as serum fatty acid levels would be elevated. This elevation would be a result of the inability to metabolize fatty acids via the beta oxidation pathway. Option D is plasma glutamine. This diagnostic study would show that plasma glutamine levels can be used as a diagnostic as well as for treatment guidance in urea cycle disorders. And in urea cycle disorders, they will initially be elevated, which is diagnostic, period. So moving on to the workup. So the full blood workup was ordered for this female, and the data is presented below. So essentially the initial blood and ammonia level was elevated at 314 micrograms per deciliter, and the urine uric acid level was markedly elevated at 473 micromoles per liter of creatinine, and the plasma citrulline level was stated as normal. However, it's slightly lower than normal, but not by much. So the question stated is in this patient where uric acid levels are elevated, list one urea cycle enzyme that is most likely deficient and one urea cycle enzyme that is least likely to be impaired. So the answer is as follows. In this patient presentation, we see an elevated plasma ammonia, an elevated uric acid, and normal to slightly low levels of plasma citrulline. We do not have access to our carbamyl phosphate synthetase 1, our carbamyl phosphate levels, or arginine levels. However, in the setting of elevated urine uric acid, we can postulate that carbamyl phosphate synthetase 1 is properly working and not deficient. We know this because we have elevated levels of urine uric acid and low to normal citrulline. This would suggest we are shunting the carbamyl phosphate to the cytosolic pathway where carbamyl phosphate synthetase 2 is producing our elevated levels of urine uric acid. This would further suggest we have a deficiency in ornithine transcarbamylase, and we are not using the carbamyl phosphate pool to synthesize normal amounts of citrulline. Moving on to case number 3, a 47-year-old man presents with severe pain in his right great toe. He is unable to bear weight on his right foot, and there was no apparent trauma. He reports pain. The pain started last night and continued to increase in severity. Based on his physical exam and laboratory findings, he is diagnosed with gout. Gout can be caused by several different mechanisms, and blood samples are drawn and urinalysis is performed. The results from this individual are stated here. The patient's plasma urate level was 10.5 and normal is less than 7. His urinary acid level was 215 and normal is 413 plus or minus 78. So the question is, what is the best explanation for the presentation of gout in this individual and please explain why the other choices are not consistent with the data, or what additional information you may need to decide the root cause. So stated here are 1, 2, and 3. Number 1, overproduction of purines. Number 2, decrease of salvage of purines. And number 3, decreased urinary excretion of uric acid. So the answer is as follows. The patient presentation coupled with the plasma and urine concentration of uric acid suggests this patient has hyperuricemia, which is overproduction of purines as well as decreased urinary excretion of uric acid. In order to better understand if the clinical presentation had a decreased salvage of purines, I would need to know if there was a concomitant deficiency of either enzymes, adenine phosphoribosyl transferase or hypoxanthine guanine phosphoribosyl transferase. A deficiency in either of these aforementioned enzymes is unlikely, as these deficiencies are associated with multiple comorbidities that are not mentioned in our clinical correlate. There is a higher likelihood we have an overproduction of purine, proper salvage of purines, and a decreased excretion of uric acid. Ultimately, this would cause our presentation of gout. The question goes on to discuss how the patient tells you that he recently switched from diet soda to regular soda because he read that the fake sugar diet soda was bad for him. He tells you he drinks 4 and 5 liters of soda a day. And so the question is, what is the potential impact of his dietary modification on the presentation of gout? And the answer is as stated. Increased consumption of fructose leads to hyperuricemia through the metabolism of fructose by fructokinase. The primary cause of hyperuricemia is mediated by the phosphorylation of fructose into fructose 1-phosphate, catalyzed by fructokinase, where this reaction is without negative feedback. In this reaction, we see a decline in intracellular phosphate and ATP. As we have learned in recent units, the fructose 1-phosphate will be broken down into D-glyceraldehyde and dihydroxyacetone phosphate. In the setting of increased fructose intake through the diet, such as in our case, there is an accumulation of fructose 1-phosphate, and with this accumulation of fructose 1-phosphate, we will see a decrease in intracellular phosphate. This process stimulates AMP deaminase, where we will catalyze the degradation of AMP to inosine monophosphate, thus increasing purine degradation. As discussed, purine degradation will ultimately increase plasma uric acid levels. Fructose will simultaneously trigger uric acid synthesis through additional processes, as in the case of amino acids such as glycine. As we see in Western diets, prolonged intake of high levels of fructose will inhibit the renal excretion of uric acid. By these mechanisms, we will see clinical presentations of gout where our studies demonstrate an overproduction of purines, a normal salvage of purines, and a decreased excretion of uric acid in the urine, all leading to hyperuricemia. This concludes my Unit 4 Case Connections presentations. Thank you for your time.